As we come to the end of the second day, the diabetes is at an end and tomorrow the endocrine is going to start. So spectrum of insulinization, what more could be used to treat diabetes? It's 100 years of insulin discovery, and what an appropriate topic to end the second day of the diabetes related topics of NDiab Summit. Tomorrow at 9 a.m. it would be an endocrine day altogether till 1 in the afternoon. And to present to us is Dr. Indriya Maisnam, who's DM in endocrinology, FRCP Edinburgh and FACE USA. She is a senior consultant endocrinologist, Department of Endocrinology, IPG, MER and SSKM Hospital, Kolkata, Charnock Hospital, Bellevue Clinic and RSV Hospital. The clinical and academic experience of 17 years backing her up, and of 52 publications in peer-reviewed national and international journals. Over to you, Dr. Indira.
Thank you very much. Thank you for having me here in this unique and special meet. So my topic, as has been announced, is spectrum of insulinization from hospital admission to post-discharge. So these are the agenda for discussion: the relevance of good glycemic control in hospitalized patients, understanding need for managing both the components of dysglycemia, that is the fasting as well as the postprandial, and managing hyperglycemia after the discharge. So glycemic control in the hospitalized patients is very important because the poor glycemic control is associated with increased risk of mortality, we know. So this is the mortality this is one study which showed the mortality in patients with normal glycemia, with known diabetes, and with newly discovered hyperglycemia, where we see that the newly discovered hyperglycemia was associated with a greater risk of mortality. Also, not only is the hyperglycemia important, but the degree of glycemic variability is important. The greater the glycemic variability, there is increased length of hospital stay and increased mortality. Therefore, managing hyperglycemia in the hospital setting, anti-hyperglycemic therapy, in most of the conditions, we would be using insulins, and OADs, except for very, very rare conditions, would not be recommended mostly. Now, how do we use insulin depends on whether our patients are critically ill or non-critically ill. In non-critically ill patients, typically they would be provided a basal-bolus insulin, and critically ill patients could be offered anywhere between a basal-bolus insulin or even an IV insulin infusion. So there are glycemic targets for hospitalized patients. The threshold for starting insulin is when the blood glucose is more than 180 milligrams per deciliter. We know that the target blood glucose in the hospitalized patients is around 140 to 180 milligrams per deciliter. There could be some, let's say, adjustments in the glycemic target, a little higher level in those who are terminally ill with severe close comorbidities and when close nursing supervision is not feasible. Similarly, the RSSDI from our country has also similar recommendations. So the anti-hyperglycemic treatment in patients, in hospitalized patients, depends on what the patient is suffering from, how severe is the illness, and also how is the nutrition of the patient being taken care of. So if the patient is poor oral intake or NPO, many times we give an infusion or we give a basal insulin with a correctional dose insulin regime. If the patient has a good nutritional intake, then we give what is typically known as the basal-bolus regime along with the correctional components. But one thing which is still practiced and which should be actually discouraged is the sliding scale insulin, which should be strongly discouraged. So if we see the changes in the blood glucose concentrations in patients treated with a basal-bolus regime, we see that there is a marked improvement in the blood glucose with very little glycemic variability. But in someone who is rapidly improved after switching to a basal-bolus insulin regime. So the basal-bolus insulin regime is preferred over the sliding scale in the management of non-critically ill hospitalized patients with type 2 diabetes. Now, what are the criticisms against the sliding scale insulin regime? So it is non-physiological. Patient experiences a roller coaster ride of blood glucose, suffering between swings of hyper and hypoglycemia, as we can see here. There is poorer glycemic control and increased risk of both severe hyperglycemia as well as hypoglycemia, and it is not individualized, and this is a reactive approach in the sense that the action of correcting the blood glucose is taken only when the blood glucose has risen up to a certain level, or in other words, when the damage has been caused. So the basal-bolus regime is superior because it's a physiological way of glycemic control, because we know normally physiologically we have a basal insulin secretion in our body, and there are boluses of insulin secretion which coincide with our meal timings. And therefore, not only ADA, but most of the authoritative body recommend the basal-bolus regime in inpatient setting. So the addresses of many components of the hyperglycemia. That is, the basal would specifically target the fasting state insulin requirements. The bolus would target the mealtime insulin requirement, and the correctional would address the unexpected glucose elevations or dispose of elevated hyperglycemia. So in most of the cases, implementing basal-bolus therapy to manage inpatient hyperglycemia in non-critically as well as critically ill patients will improve the glycemic outcome with fewer hyperglycemia and hypoglycemic agents. So when we give the basal-bolus regime, we typically calculate the ideal dose of insulin in somebody, an insulin naive person, as something like 0.4 to 0.5 units per kg of the ideal body weight. Somebody who is obese would need a greater amount of insulin. This is the starting dose of the total daily dose insulin requirement. And these would be adjusted based on the capillary blood glucose monitoring, which we would do. So typically, after calculating the total dose, around 40 to 50% is given as bolus, basal, and another, let's say 50 to 60% is given in bolus, which is divided typically into 3 major meals. And then we measure the blood glucose typically pre-meal, but also post-meal, to understand the insulin response in these individuals. Sometimes we may have to measure the blood glucose at, let's say, 2 a.m. or 3 a.m. to look for the nocturnal hypoglycemia. And then we adjust the insulin level dosing based on our target blood glucose, which in most of the patients is 140 to 180. So this is just an example of correctional insulin protocol. It's not necessary that we follow it as a hard and fast rule. There is, in every person is an individual. Every person's response to insulin would be different, and therefore individualization is the key to good insulinization and good glycemic care in patients. So in hospital requirements, the basal bolus is effective glycemic control, lower risk of hypoglycemia, flexible and simple dosing, and usage in the entire range of population. So, and if we look at the typical basal insulin, for example, the degludec, it targets the fasting glucose so well, as we can see after starting at admission, and on day 4, by that time, the fasting blood glucose is very well reached, and the average blood glucose at admission and at discharge is so well improved with the use of degludec, where we've seen that there is a mean change of fasting blood glucose, as we can see here. And also, not only does it improve, or let's say lower the blood glucose to normal, it also reduces the glycemic variability, as we can see here. And the average mean glucose in this example is 152 milligrams per deciliter, with a range between 115 to 195, showed that it is a good predictor of not only a good glycemic control in the sense that it targets the fasting well, but also decreases the glycemic variability to a favorable extent. So this is about an example of a basal. What about a bolus? So the bolus could be the human regular insulin, or it could be the analogs like aspart, lispro, or glulysin, or let's say the ultra rapid acting analogs like faster aspart, which we know is available as FIASP, and we are using it, I think, quite a lot in the hospitals these days. So it has got an, compared to, let's say, a rapid acting analog, this ultra rapid acting analog FIAS is associated with greater reduction in the postprandial glucose, and also in the as we can see here, the expected treatment difference is around 0.1%. Also, combined with the degludec, there is a lower risk of hypoglycemia, and therefore combining a basal bolus insulin, like let's say a degludec with a fast-acting aspart, results in targeting both the fasting as well as the postprandial with a decreased chance of hypoglycemia. So this is what the slide is trying to show, that there is a decrease in the overall hypoglycemia, the daytime and the nocturnal hypoglycemia. And also, there is a marked flexibility in the case of daycare procedures with degludec, where this CGM study, which was done in patients who were undergoing a total colonoscopy, showed that the use of degludec resulted in stable glycemic profile, and no patients undergoing the colonoscopy experienced hypoglycemia during the fasting period of 24 hours with degludec. So insulin degludec can be used safely prior to the procedure requiring NPO with the least chance of hypoglycemia, because it more or less, to a large extent, mimics the typical basal insulin secretion profile that occurs in normal individuals. Again, the beauty of faster acting aspart is that, yes, it addresses the postprandial hyperglycemia. There is lesser chances of delayed hypoglycemia, and also because it can be just given before the start of the meal or even after the start of the meal, it is very convenient for the patient, especially in the hospitalized setting, when we are not aware when the patient would take the food or how much food the patient would take, and things like that. So even giving it after the start of the meal is a very could be a preferred option in hospitalized patients. And again, used in a wide range of population, whether patients are uncontrolled diabetes, whether they have renal impairment, hepatic impairment, elderly, and pediatric group. Now, coming to the understanding the need for managing hyperglycemia. So if you look at the impact of the COVID-19 related lockdowns on the glycemic parameters in the Indian evidence. It's not only Indian evidence, it's throughout we know that the COVID-19 the lockdown itself has resulted in worsening of the blood glucose control because of lack of physical activity, because of, let's say, not visiting the healthcare setup regularly. And so these are the papers from India where it was found that carbohydrate consumption and frequency of snacking actually increase in the patient, resulted in weight gain, and also the exercise duration decrease because of, let's say, fear of going out because of the pandemic, etc. And during the lockdown, postprandial blood glucose levels increased significantly with in this study, but also overall there was worsening of the glycemic control. Now, high postprandial and high fasting contributes to both the HbA1c, and this could be because of the fact that because of many factors. One of the important factors could be that there is delayed insulin initiation, or even if the insulin is initiated, typically initiating with a basal insulin in a, let's say, in an OPD setting may not address the postprandial hyperglycemia that is typically associated with our Indian diet. So the choice of insulin initiation should take into consideration, this is in the OPD settings actually, the Indian realities, which is high carbohydrate diet, high postprandial glucose level, patients uncontrolled on multiple OADs, and need for safety and convenience. So in the outdoor setting, in the OPD setting, can OD basal insulin is enough, be suitable in the case of a high carbohydrate diet, offer direct control of postprandial glucose? No. Is it suitable in case of delayed insulin therapy? In delayed insulin therapy, both the prandial as well as the fasting, postprandial as well as the fasting glucose are increased, and would only a basal insulin affect control the total or the fasting and postprandial glucose? So a combination of quick release prandial insulin with slow release basal insulin could be the ideal combination. Before this combination arrived, we have already been using the premixed insulin, human insulin, or premixed human insulin analogs. But here, this is a co-formulation which takes into account the advantages of the basal, purely basal insulin like degludec with a purely prandial insulin like aspart, which is available as IDegasp, and therefore the blood glucose profile that is provided is the pharmacokinetics of this agent is that it is flat and stable, steady state, and because the insulin monomers slowly and gradually dissociate, whereas the prandial component actually results in the targeting of the postprandial glucose, as we can see here. So the IDegasp or the co-formulation at steady state has distinct prandial and basal glucose lowering effects, making it a good insulin that would target both the pre-prandial or the fasting and the postprandial glucose. So, so this was just an introduction to the use of, let's say, the premix, the co-formulation insulin, the advantages of co-formulation, and how could you use it in patients who are already admitted and now who were on a basal bolus regime and now ready for discharge. So managing hyperglycemia after the discharge. How can we offer effective, safe, and convenient insulin therapy to patients post-discharge from routine ambulatory care? So once daily IDegasp versus basal bolus regime results from the step 1 trial, where we can see that there was a similar HbA1c reduction, significantly lower risk of nocturnal hypoglycemia, where we can see this gray color is the glargine with the aspart, whereas the blue color is the IDegasp, where we can see that there was lower incidence of nocturnal hypoglycemia compared to glargine. And not only was the HbA1c similar, not only was there decrease in the chances of hypoglycemia, but also the insulin requirement was lesser in this trial with compared the IDegasp with basal bolus regime of a glargine and aspart. And this is results from the step-by-step trial. So the study claims that the 2-in-1 injection is comparable to, let's say, 2 different or 4 different injections. Again, there is real-world evidence on the usage of IDegasp in post-discharge COVID-19 type 2 diabetes Indian evidence, which was published presented in the ADA. So this was a single-centered retrospective study from 1st June to 31st December 2020. Type 2 diabetes who were non-compliant to basal bolus after discharge with COVID-19 management and age more than 18 years. So there were 67 patients, small study, 33 female and 34 males, and the age was around 59 plus minus 10 years. The BMI, they were obese. So after 14 days of discharge, when the patients were discharged on a basal bolus regime, which they were actually receiving in the hospital, it was found that 88% were non-compliant with the basal bolus therapy, because we know that the basal bolus therapy is labor intensive for the patient in the sense that they have to measure their blood glucose, they have to measure their carbohydrate content of the food, and then accordingly decide their pre-meal insulin dosing. And as a result of which 88% of the patients were non-compliant with the basal bolus therapy and 100% failed to achieve the glycemic goals. Now, these patients non-compliant with the basal bolus were switched to IDegasp and EMPA plus minus EMPA-LINA plus 1 gram metformin. And after 13 weeks of therapy, there was a improvement in this hyperglycemia, 100% compliance to therapy, and there was 0 episodes of severe and nocturnal hypoglycemia and significant reduction in the glycemic parameters with better compliance and improved safety. So however it is, but this was a very small study. Also, they used empalina with this combination. So it is with the combination of IDegasp. So it is actually very difficult to point out what was responsible for the benefit. But at the same time, I would like to point out that in patients who are already on a basal-bolus regime, in the hospital, typically discharging them on a basal-bolus regime is very difficult for the patients to follow. In that case, in most of the cases, we change our patients to a premix regime, and a premix co-formulation like this could provide a better basal coverage for these patients, and thereby translating into better glycemic control. So this study showed that switching to IDegasp plus OADs was an efficacious and safe alternative in post-discharge COVID-19 patients treated with dexamethasone during the hospital inpatient stay. Again, I would like to point out this was a single center study, only 67 patients. They also took oral agents as well as degludec, the combination of aspart with degludec, and therefore difficult to point out which was responsible, but still in patients who are admitted with COVID, or for that matter, for any other reason, needing basal-bolus therapy in the hospital, when we discharge them, typically we would do so in most of the cases on a premix regime or a premix, let's say, or a co-formulation. So to summarize, glycemic control in the hospital should be a priority, both to enhance the quality and patient stay and to reduce the cost related to the length of stay, and also definitely reduce the mortality also. Uncontrolled diabetes leads to higher ICU admissions, increased morbidity and mortality, and hence it's important to ensure good glycemic control in people with type 2 diabetes. In tune with the Indian realities of diabetes management, once the patient is discharged from the hospital, or even if we, let's say, initiate a patient with insulin in the OPD setting, insulin that addresses both the prandial as well as the fasting are important, and co-formulations like IDegasp are welcome because they offer the total control and can help achieve glycemic goals with safety. In hospitalized patients, always the choice of insulin in most of the cases would be a basal-bolus regime. Some patients would be needing even an IV insulin infusion. Post-discharge, IDegasp offers the convenience of a single device and providing effective glycemic control and safety as compared to complex basal-bolus regime during routine management of diabetes. Thank you so much.
Thank you, Dr. Indira. Thank you so much for your. I would come back after a small video. Thank you. I think Professor Debballo Shannal and Professor Anirban Majumdar are there. If you could unmute and we could have a discussion. We are just 5 minutes, a couple of questions we can take together, 5 to 7 minutes to this scheduled time of conclusion of today's events. Professor Majumdar and Professor Shannal, if you could join us. Indira, the first question, Dr. Indira, for you is, in the hospital scenario for a basal bolus, do you consider that the generation 1 basal insulin or generation 2 basal insulins are more appropriate?
I think so that's an important question. I think both groups of insulin, the generation 1 as well as the generation 2, both are used. both are appropriate. There is no problem with the use of, I would not say there was not, both are appropriate, I would say. But I think the later generation basal insulins are attractive in the sense that they have less peak, or let's say peakless, compared to, let's say, first generation basal insulin, where at least a little peak is there, which can result in nocturnal hypoglycemia. So also they are low, so both are preferred, but yes, I think the extra advantage of the newer generation is that because of being absolutely peakless, the chances of a nocturnal hypoglycemia are less.
India, I think there is some controversy regarding use of this degludec in the hospital practice, that you need to uptitrate the dose at least after 3 days time. And sometimes, in an acute clinical care setting, we actually titrate the dose almost daily. So here is the catch. Now that makes a little difference whether we can use this drug in an acute care setup or not, where actually we need to uptitrate the dose almost daily, which is possible with the conventional glargine. However, Shomu, I'm a little bit in favor of glargine U300, because in our hospital, if you advise our paramedical staffs to give glargine at say 10 p.m. or 9 p.m., whatever you want to give, say 9 a.m. So it is not always possible for the paramedical staffs to inject the injection exactly on the same time. So if you give IU300 variety, that will give an extra edge that you can actually, you have little some
plus
amount of
minus 3 hours.
flexibility, plus minus 3 hours. So it will become convenient on part of the paramedical staff. Even if they forgets, they can inject it after say 1 hour or so, and still the regime remains perfect.
Dr. Sharnal, your opinion?
Yeah, again, we are gathering experience with regards to glargine U300. Started a few questions on that. We had previous experience with, very small experience, probably inadequate experience with degludec. Though that time, the titration was a little bit difficult, but now the recent evidences also suggest that with degludec also, there is no problem with regards to daily titration.
Yes, it's just
there
that
are papers now coming in.
Yes.
So that is also something which is there. Probably we need to gather more experience with regards to both these molecules, because one advantage probably is that, especially in the hospital setting, nocturnal hypoglycemia is a big issue. And, getting a nocturnal hypoglycemia is very risky, because the patients are more sick, and also from the patient, relatives point of view, that's a problem. Lot of times it's not monitored. So if we have the option of these two second generation of basal insulin in the hospital setting, where patients are more critical, more likely to develop nocturnal hypoglycemia, these may have added advantage. Probably we require, and there are papers with both of these molecules with regard to better efficacy, and also probably more time in range, the new evolving concept. So probably we require more experience and better follow-up to have more experience. We still have inadequate experience. That is my personal feeling, that our experience we generally still stick with our age-old glargine U100 in most of the settings, but still we require more experience with both these molecules.
With a time range over a short period of hospital intensive care extrapolates into better outcomes. Is there any paper on that? Greater time in range in that critical period. Of course, we know that glycemic variability did have adverse cardiac outcomes, etc. But 1:1, looking at time in range to outcomes. I am not aware of papers. Anyone?
No.
No.
But there are some data of use of degludec in the hospital practice.
Yes,
so
yes.
This is recently published, where they said that at the 5th day, and discharge time was not delayed, and I think on the day 5, you had a similar A in both the arms. So
yeah, the recommendation came from ADA probably year before last, when they first recommended for nasogastric feeding patients who were NPM and use of degludec was favorable. So now they have several recommendations this year that you can use them. Probably we need better experience with degludec. And also there are issues with regards to cost, availability in hospital pharmacy, which are major issues as well.
So I have been using degludec quite a lot in the hospital settings, and I can say that I think as Dr. Sanyal also pointed out, titration is not necessary that we have to do every 4 days, just at the steady state, concentration takes that much time to come. And also in my personal opinion, personal experience, I found that the insulin requirement for U300 glargine was actually a little higher than what was required for the use of degludec. So again, that's my experience.
Yeah, that's supported. Perhaps a U300 is required a bit more than U100.
Yes,
that's
so ultimately that translates to higher cost also. These are expensive molecules. So ultimately they translate to higher cost. There's another question
for you, Dr. Indira, before we move into the panel again. The question says that although in the clinical trial, it had been seen that twice daily co-formulation was nearly equal to that of a basal-bolus regime with lesser risk of hypoglycemia, but we Indians are very, very high carb consumers. And many of our basal-bolus patients do require a bolus injection proportion, which is significantly higher than that of the basal. So in those patients, would you like to try the co-formulation?
So in such group of patients, again, so typically, I think in many of our patients, we start with the co-formulations once a day. And then which would address that particular meal and the fasting. And if that is not addressed, sometimes we go to co-formulation twice daily, but other options could also be that we use the co-formulation once and give bolus injections, let's say before another major meal. So that would convert to, let's say, at the most 3 injections, lesser than the 4 injections.
Thank you. And would you really look at, this is my personal question, would you really look at the co-formulation in the in-hospital scenario, particularly?
No, not at all.
Okay.
I hope I didn't convey that message. It would be only in the patients on discharge or in the OPD, but never in the hospital setting, never.
Okay. Thanks to all the speakers today. It was a brilliant day of knowledge exchange, and thanks to everyone who, despite being a Saturday, had joined it. We had clocked plus 3-figure plus at some points of time, which is decent for an online conference. Thanks, Indira, for being there with us. Thank you, Professor Debmallo Shannal and Professor Anirban Mojumdar. You have always been spearheading this conference and the actual men behind the scientific show. Thanks for being there.
Thank you so much. Thank you for having me.
And we have to look tomorrow whether evidence-based medicine really has evidence or not. What evolves out of evidence-based medicine. And it was a wonderful talk with a lot of insights from Professor Shubhankar Choudhury, which didn't say that evidence-based medicine is not required, but which pointed out perhaps that precision medicine, to individualize the needs and care and not to take the statistical figures. I would refer to one famous quote from Neville Cardus, who was a journalist, a cricket addict. He used to write a lot about cricket. He once said, the scoreboard is an idiot. To elucidate that, he said, a 200 plus in a flat pitch cannot be compared with the 98 of Gundappa Vishwanath in Chipak against the fiery Andy Roberts. The 98 is much more enjoyable. rather than the 200 from Geoffrey Boycott on a flat pitch over 1.5 days. So maybe at times evidences are like that. Thank you so very much. Have a wonderful night, and we meet again after breakfast, or maybe over a virtual breakfast tomorrow morning at 9 a.m., where we would have Dr. Sujoy Ghosh and Professor Ken Ho addressing panhypopituitarism. Good night. Shubharatri to everyone.
Thank you. Good night.
Thank you. Good night.